Ahmedabad. He's a past secretary of IRA. He has done his DM clinical immunology and rheumatology from SGPGI Lucknow. He has got multiple publications to his credit. The areas of interest are primary Sjogren's, palindromic rheumatism, and humanities in medicine. Other faculty for today is our very own Dr. Shubda Kalke. She is my classmate from a very close friend. She's a renowned rheumatologist in Mumbai. So over to both of you. And Akansha, you can share the slides. Yeah.
Yes, ma'am. Good morning to everyone present here. Should I start the presentation?
Yeah.
Yes. So today, I'm Dr. Akansha Kapoor, first year DM resident in Bharati Vidyapeeth Medical College, Pune. I'll be presenting a case of a middle-aged lady with multiple joint pains, heartburn, and skin tightening. My patient is a 45-year-old homemaker, resident of Ambajogai, which is a small town in Maharashtra. She presented to our center in June 2023 with complaints of bluish discoloration of fingertips on exposure, pain in multiple small and large joints, heartburn, and regurgitation of food for a duration of 10 years. She also had complaint of tightening of skin over her fingers, feet, and face for a duration of 6 years. She is a known case of hypothyroidism since the year 2017. She presented with a complaint of bluish discoloration of fingertips on exposure to cold, which was first noticed 10 years back when her age was 35 years. She noticed this complaint for the first time while washing her clothes with cold water. She noticed that it improved after rewarming. It was initially associated with mild pain. She did not notice any digital ulceration or blackish discoloration of her digits. She also noticed history of swelling of both of her whole hands, such that she was unable to make a fist. She was unable to negotiate her ornaments like rings and bangles. This complaint was associated with intense itching without any visible rash. This itching and swelling, however, subsided on its own in the next 6 months. She also had complaint of pain and swelling in multiple joints, which was insidious in onset, additive in nature. Initially, both the wrists were involved, followed by small joints of the hands. Both knees got involved, left more than the right sequentially. This joint pain was associated with the early morning stiffness of more than an hour. Till 2018, she relied on over-the-counter painkillers, which only partially relieved her symptoms. In 2018, she presented to a tertiary care center where she was told that she has some form of arthritis, and she was advised to take a weekly medicine, which she took for around 2 years from 2018 to 2020. But she stopped in March 2020 owing to only partial response to these medications. In June 2023, that is the presentation to our center, she has come with pain and swelling in small joints of hands and both knees, which have increased since the past 3 months. She also has complained of burning sensation in the chest, which worsened on lying down, especially after heavy or spicy meals. It was sometimes associated with regurgitation of food. It was not associated with abdominal pain, nausea, or vomiting or loose stools. For this complaint, she had underwent an endoscopy in September 2022. She was started on some oral syrups and tablets, but only partial relief was there to these. She also has complaint of thickening and tightening of skin over her hands and feet and tightening of skin over her face for a duration of 6 years. This tightening was insidious in onset, gradually progressive initially. Yes, sir?
No, you can carry on.
Yes. Initially, it was noticed over her, the tightening she noticed over her hands, and eventually she noticed that this tightening had progressed to involve the skin over the forearm as well. Inability to, she also noticed that there was an inability to open her mouth fully. She also noticed gradual progression of darkening of skin over her face, forearm, hands, and feet. There is no history suggestive of thickening of skin over the trunk or abdomen. In April 2023, she presented elsewhere with a complaint of low-grade fever, generalized weakness, cough of a duration of 2 months. This was, however, not associated with any duration or any episode of hemoptysis. There was no complaint of any breathlessness or significant weight loss at that time. She was told to have lung tuberculosis on the basis of her CT scan, which was done in April 2023, and was started on ATT by a pulmonologist. After around 2 weeks of starting this treatment, she reported improvement in her symptoms. Currently, her 6 months of her ATT has been completed, and she's no longer on that treatment. No complaints of any photosensitivity, recurrent oral ulcers, or Zika symptoms. No history of any skin rash. No history of pregnancy-related morbidities. No history of any periorbital puffiness. No history of difficulty in getting up from squatting position or reaching for objects overhead. No history of breathlessness on exertion. Should I continue, sir?
Akansha, what is the duration of her acidity?
Ma'am, 10 years.
Okay. And the doctor she had seen was a local doctor or rheumatologist, or what type of doctor had she seen? Do you know?
When, ma'am? For the acidity?
Before coming to you.
Ma'am, before coming to me, she
in
had
2018 or whatever.
Ma'am, a medicine specialist only. No rheumatologist was.
So when she saw you, she saw the rheumatologist for the first time, right?
No, ma'am. In between 2020, 2019 also, she did go to a rheumatologist, but did not continue treatment with him.
Okay.
So just one visit was there. I will be talking about that in the treatment history part.
Okay. Sapan, you want to ask anything?
I think let her finish the history, then maybe we can.
Personal history: consumes a mixed diet. Sleep is unaltered. There is no alteration of bowel or bladder habits. She does not report any addictions or tobacco abuse. Obstetric history: she attained MENAR at the age of 13 years. She has 5 children. All of them were delivered normally, vaginally. All of them were uneventful deliveries. Last childbirth was 21 years ago. There are no history of any pregnancy losses, and she attained menopause a year ago. Past history, as already mentioned, she is a known case of hypothyroidism, diagnosed in 2017 on thyroxine 50 microgram. There are no other comorbidities, no history of any arthritis or CTD-like features in the family. Treatment history, ma'am. So in March 2018, she, as I already mentioned, I have consulted the prescriptions that she had brought to the hospital in June 2023. So the March 2018 prescription showed the weekly medicine was methotrexate, 15 mg per week, and prednisolone and hydroxychloroquine. In 2019, she had visited a rheumatologist who had, for her Raynaud's, who added tablet tadalafil and nifedipine to the existing regimen. However, in March 2020, she stopped all medications by herself. In September 2022, she developed an episode of severe dyspepsia, for which she was admitted for a day. She underwent endoscopy for this symptom, and she was started on oral proton pump inhibitors. She also had arthritis, persistent inflammatory arthritis. So she was probably started on azathioprine on escalating doses. In February 2023, this azathioprine was stopped owing to the low WBC count, and she was continued on prednisolone and HCQS alone. In April 2023, she had complaints of low-grade fever, cough, for which she was started on ATT on the basis of her HRCT findings by a pulmonologist. So summary after history. She's a 45-year-old lady presented with a 10-year history of Raynaud's phenomenon, inflammatory polyarthritis involving small joints of hands and knees, with a preceding history of puffy hands and dyspepsia. A 6-year history of skin thickening and hyperpigmentation involving the face, forearms, hands, and feet. and a known case of hypothyroidism and a suspected case of pulmonary COX on treatment. Currently, in June 2023, she presented to us with a flare of inflammatory polyarthritis for the past 3 months. The differential diagnosis that I would like to consider at this point, limited cutaneous systemic sclerosis. It looks like a connective tissue disease, limited cutaneous systemic sclerosis, or MCTD, or an overlap MCTD, RA systemic sclerosis overlap. Should I go ahead, sir?
Yeah, finish your history part and then we can.
Okay. So points in favor of the systemic sclerosis at this point that I could think of was a long history of Raynaud's GERD, skin thickening. She's a middle-aged female. A long duration of symptom is there, and slow progression is there. Points against I would could think of was she had a history of puffy hands, which is not that common in scleroderma, and no history of digital ulcers despite such a long history. In favor of mixed connective tissue disease, she had history of puffy hands and a long history of Raynaud's phenomenon. Although she did not have any symptoms related to muscle weakness or any erythematous skin rash or SLE features or features of any other connective tissue disease. On examination.
Wait,
Yes.
Sapan, you want to ask
Yeah,
anything
you
on
can.
this?
So one of my first, and in fact you sorted that out. My question was when she was not able to make a fist initially.
Yes.
Do you think it was because of arthritis or it was because of the puffiness of that you see in early stages of these diseases?
So initially, when she was not able to make a fist, I think it was because of the puffiness, which subsided for after 6 months, and then she developed she could notice the arthritis part.
Yeah, because so the arthritis was later on, but now she just had an episode of arthritis, right? Fresh arthritis 3 months back.
Yes.
So this is not puffiness because obviously she's now gone into
Yes.
skin tightening.
Yes, sir.
So in clinical trials of scleroderma, what
Yes,
is the criteria generally used for as a starting point? Are you aware of that?
So usually the modified Rodnan skin score as a disease outcome is used for.
That's for the examination part. For the history part,
Okay.
what do they start with usually? If you
It's a Raynaud's duration of
it's a non-Raynaud's is what they actually count. I believe it might be because see in your case, for example, from Raynaud's to skin tightening, it was almost 4 or 5 years. Sometimes it is shorter in some people, in some people it is longer. So that's why that might be one reason why normally clinical trials, they, if you look at the criteria, they say
Yes.
non-Raynaud's se kab shuru hua tha. That is how they start stuff. So that's important to know. The other thing is you said, see how much time do we have? 11:06 because we'll have to divide into examination and then last questions. We have to finish by 11:50, right? As I gather.
Yes, 11:50. We should maybe another 5 minutes for feedback, but yeah.
Yeah. So and then you said regurgitation and all those things which started with the Raynaud's itself, probably 10 years back.
Yes, so she's not able to distinguish between the two complaints actually, sir.
So she actually started having internal symptom before she had the skin manifestation. That is what it means, right? Apparently. क्योंकि तब reflux तो शुरू हो गया था उनको, which is slightly off because normally all of this goes together. But what proportion of scleroderma patients have GI manifestations, and what are the manifestations of GI manifestation of scleroderma?
Sir, mostly esophageal dysmotility is a common feature of scleroderma. Apart from that, sir, there are below the in the stomach they can have a gave-like symptoms or early satiety symptoms. Sometimes abdominal pain can be there. Apart from that, sir, subacute intestinal bacterial overgrowth can also be seen in scleroderma patients. But most commonly, esophageal dysmotility is seen in around 80 to 90% of the patients of scleroderma.
Especially when I have CREST syndrome, right? So there can be some others. You can start with dryness of mouth itself. In the fibrotic stage, you can get some dryness also in the mouth in these patients, not necessarily Sjogren's overlap.
Okay,
You
sir.
can get oral ulcers as a part of every connective tissue disease. And then going lower down, I'm sure you know about watermelon stomach.
We gave, yes, sir.
Sometimes they come in that way. And then what is pneumatosis intestinalis?
Sir, air in the wall of the intestine. I'm not exactly
Not
sure.
very common, but sometimes that is also seen with these patients, right? And then you said, bacterial overgrowth and those things. And perhaps one of the most important symptoms which we don't ask patients is the anal sphincter problems. A lot
Right.
of these scleroderma patients have anal sphincter issues, starting with itching, incontinence, and because of privacy issues, we don't ask and they don't tell you. I think somebody really needs to study anal sphincter disturbances in scleroderma, which is a very nagging manifestation from them I've gathered over time. So, and then there are obviously hepatobiliary. I'm sure you are aware of the liver. What happens with scleroderma?
Sir, primary biliary sclerosis.
You can have an overlap with PBC. It's
PBC.
now called cholangitis, right? The new name is cirrhosis is an old nomenclature now, I'm told. My MD students tell me. So the new name is primary biliary cholangitis.
Okay, yes.
Cirrhosis has gone as nomenclature. So you can see PBC overlaps and sometimes autoimmune hepatitis and those things. Which this would complete the list of your GI manifestations of scleroderma. Regarding the history, otherwise, I think I'm not sure about the tuberculosis. Taking the history, were you sure? Pulmonologist se dekha hai, to I would respect that, since you said that there was a pulmonologist who treated. But after taking since you have taken the history in detail, how sure are you that this was really tuberculosis, or was it something else?
So my impression at the end of the history that the ATT was started on the basis of CT scan. Her microbiological diagnosis was not there. So I would still say that it was a suspected case of pulmonary tuberculosis. It could have been because the cough that she described was dry cough, a duration of 10 months, no hemoptysis, no expectoration. So it is an atypical presentation for a tuberculosis.
So then what do you think would be the differential there?
Sir, early ILD could be.
That was what I was trying to ask. That is it ILD or is it because? But since you said pulmonologist, then I started respecting because I'm sure they would know that this is. But again, that is something you would like to keep in mind. So
Yes,
at the diagnosis part, maybe you can include the organ manifestations also. You put a good list of differentials. If you can go to that scleroderma first and then MCDD, and so you could put the organ scleroderma with, of course, musculoskeletal involvement, GI involvement, and that completes a list of the diagnosis and the organ involvement, which is very important to know. And maybe the lung is query. We are still not sure about the lung, right?
Yes, sir.
About the differential, I don't know if Shubhada has something to say with the second and the third differential.
Actually, just go to different your explanations. Sapan has already covered that. Next.
The next slide with the
Yes, ma'am.
yeah.
So the puffy hands, at this stage, we don't know whether it is history. So we don't know whether it was beginning of arthritis at that stage or beginning of Raynaud's, because sometimes that also can present with puffy hands. So can't be sure at this stage that it is a point against scleroderma. Is just one point that I wanted to make. And again, MCTD, the muscle weakness doesn't have to come all the time. And sometimes on history, you may not be able to get it unless when it is gross. You know, his patient will tell you only when it is gross. So again, point against, I think at this stage, you don't want to differentiate between the two. Differentiating other connective tissue diseases is relatively easy because you have skin tightening.
Yes, okay.
But amongst these three, I think on history at this stage, it is very difficult to differentiate. The point I wanted to make about breathlessness and CT and diagnosis of it's already discussed, so I don't want to visit that again. Where any of the investigations are there, or you will be covering them later in the history?
I have included the investigations are there, ma'am. After examination, I have included the.
That's fine.
So there are the extra marks for you for doing that. I would always welcome without investigation. Most of my MD residents, And I remember Amita madam always used to say कि investigation include करोगे तो ज़्यादा problem होगा because they will go into the ANA patterns and those things. So it is always better to come with the clinical diagnosis first and then move to the investigations. I think extra.
Yeah, in fact, Dr. Joshi himself, whenever he saw the patient, he used to keep all the reports aside
बिल्कुल
till
बिल्कुल.
he has finished history and examination, and only then we would look at the reports, so that you don't bias your mind with those reports.
पर अभी हम लोग old timer हो गए ना, so
हो गए.
nice to see the younger generation. I think that's the right way. Please go ahead with the examination. Yeah.
Yes, ma'am. So my patient is a middle-aged female, moderately built, sitting comfortably on the bed with some distress because of arthritis. Her weight is 48 kgs, height 158 centimeters, amounting to a BMI of 19.2. Vitally, she is stable, pulse 92 beats per minute, BP 100/70, respiratory rate 18 per minute, SpO2 is on room air 98%, and JBP was not raised. On general physical examination, she has some pallor. Skin tightening is present all over her face. There is reduced mouth opening. She's not able to insert more than 2 fingers in her mouth. There is some patchy hyperpigmentation over her hands and over her face. However, I could not find any telangiectasia, calcinosis, tendon fiction rub, or joint contractures. Skin thickening involving the upper limb was up till the elbow, and the lower limb up till the knees. Skin over the chest, back, and arm and thigh was spared. There is no loss of pulse space, no digital ulcers, pitting, scars, or prayer sign was absent. No salt and pepper appearance of skin. There was loss of vermilion border of the upper lip, and some puckering of lips was seen. On the MRSS that I could calculate was at that point 19, mainly involving the skin below the knee and below the elbow and face. On musculoskeletal examination, tender and swollen, they were there was restricted range of motion of the wrist joint, mainly because of the pain. MCP on the right side, first, second, and third MCP were tender and swollen. On the left side, first and second MCP were tender and swollen, and range of motion was was decreased in these joints. There were no fixed deformities. PIP, DIP, elbow was not involved. On shoulder examination, there was some tenderness present over the right shoulder. Range of motion, however, was normal. Knee bilaterally swollen and tender, left more than the right. There was pain restricted range of motion was restricted by pain. Ankle was not involved. Respiratory system examination, inspection, trachea was central, no use of accessory muscles of respiration. Respiratory rate was 18 breaths per minute. Apex was in position, not shifted. Percussion, resonant note was there in all the areas. Tidal percussion was normal. Auscultation, normal vesicular breath sounds were appreciated. No added breath sounds I could appreciate. And 6-minute walk test that I asked the patient to do turned out to be she could walk 340 meters, but the saturation, minimum saturation that I could record was 97%. Cardiovascular, upper abdomen, and neurological examination were essentially normal. Summary after examination, 45-year-old lady presented with non-deforming inflammatory polyarthritis with a swollen joint count of 9, tender joint count of 10, clinical disease activity index of around 29, skin thickening involving the face, forearm, hands, and legs with a MRSS of 19, history of dysphagia and Raynaud phenomenon for 10 years. She's a known case of hypothyroidism and a suspected case of pulmonary COX already on treatment. Is most likely suffering from connective tissue disease, either limited cutaneous systemic sclerosis or I would want to keep mixed connective tissue disease.
Why have you, Sapan, you carry on. I'll ask you.
Why she is still keeping MCDD as a possibility? This doesn't it look a clear-cut case of scleroderma now with examination. You look at the face and you know this is scleroderma.
Yes, sir.
Why are
Yes,
you still making an MCDD?
sir, actually, her arthritis was usually scleroderma does have inflammatory polyarthritis in around 20 to 30% cases, but it seemed to be very prominent complaint for her, which was a little out of proportion. And the puffy hands that she described in initial part of the illness, I
So what do you think happens in scleroderma in the early stages?
So in scleroderma also we expect the skin to become thickened and initially there is some itching and some puffiness does happen.
Yeah, so what is the tissue involved then? Why do you think there is puffiness? If you have to point out one tissue, what is the
So tenosynovitis.
वो तो joints में जब puffiness हो रहा है तो what is the mechanism going on there? What is the first thing when you have Raynaud's? What do you suspect? Which is the endothelial tissue getting involved, right? That's how Raynaud's starts. Scleroderma starts. So when you have that, you can get puffiness as a part of that itself. So scleroderma also starts with puffiness, and what you see is a result of you ask these every patient probably they will tell you there was a stage of puffiness which has gone into. So with such and then why not rheumatoid scleroderma overlap between rheumatoid scleroderma overlap? If at all you want to give so much importance to polyarthritis, which may be true. I'm not seeing the patients, you know it better. Why not RA scleroderma overlap rather than MCDD?
I could not find, despite this long history of arthritis, I could not find any deformities, any fixed deformities. So I thought it would be unlikely for her to have a erosive kind of arthritis, deforming erosive arthritis. Um,
Yeah,
that is
so
what.
you may not get that, right? You may not get that in, but between those two, um, the point here is, and I don't know if Shubhda was also probably making the same point, is that there are groups who don't believe in MCDD. I'm not sure if you've gone through the history of MCDD as a disease, and there are whole groups of people who think that MCDD eventually evolves into either scleroderma or lupus or one of those, and not everybody stays MCDD. Brings us to the question: what are the classical manifestations of MCDD? How does MCD present apart from puffiness and Raynaud, which is there in the criteria? Any other typical feature that you sometimes see in MCD जब तुम सोचते हो कि ये शायद MCD में जाएगा? Some features, clinical features.
Early pulmonary hypertension patients presenting with
One
early.
is pH can be there, and the pH in MCD is usually more like a vasculitis than a vasculopathy, which you see in scleroderma. So that's one. Other
Sir, trigeminal neuralgia.
very good. Trigeminal neuralgia. So that is another thing. Then there used to be this MCQ rib क्या rib में क्या होता था erosion पता नहीं MCQ में आता था हमने तो कभी देखा नहीं है but that used to be one thing in our time MCQs and sometimes they come with high fevers. We've seen patients coming with high fevers and puffiness and Raynaud's, and obviously what you need for MCD is actually the
Human
lab.
iron. Yes, sir, lab.
So that is the only thing which will tell you. And I don't know if this patient ultimately has just a UN RMP positivity, and sometimes because of that, residents put the diagnosis as so as we discussed that. So that was my argument here. I don't know, Shubhda, anything else?
Yeah, I just want to go. Can you start with the examination? I'm just going to go into basics. I want you to explain to me how does it matter your height, weight? Does it really matter?
Overall general health of the patient, is she, the BMI will be able to tell us the overall general health of the patient.
Why do you need to know that?
To know the disability, the functional status of the patient, whether she's how much is the disease disabling her to do her daily work.
Correct. So you want to, especially in scleroderma, we discussed in detail the GI manifestations. So you want to know whether it is affecting her dyspepsia, what is happening to her nutrition, right?
Yes, ma'am.
That is one thing. So that's why you want to know the weight and you want to know the weight loss. Now, you have mentioned pulse. Is the pulse normal?
Ma'am,
resting pulse rate.
Yes, ma'am. Ma'am, appear
Or
normal.
this would concern you and you would think of some investigations? Or 80 to 120, even if the patient is 120, you will be happy at rest?
Ma'am, if it is at rest, if it is 120, I would investigate for it
If
further.
it is 100?
Ma'am, normal pulse is usually up till at rest. It can go up till 100 in normal people also. So if it is beyond 100, I would be.
No, I think actually resting pulse rate beyond 80, when the patient is sitting comfortably, unless she is very anxious sitting in front of you, what you are going to tell her, like white collar symptoms, I would think of looking at her heart, or even the activity of the disease in general.
Ma'am, she was
And
a little
BP?
distressed about her arthritis complaints, although I've written sitting comfortably, but she had those pains when she came into the OPD. She had those arthritic pains, and she was in some distress because of that.
Okay.
Can tachycardia be a sign? That's what Shubhda is trying to say of a complication later on.
Simple examination, you are trying to think what investigations you want to do in a patient. That's the point I'm making. That whenever as a student you present a case,
Yes, ma'am.
we just pulse, BP, weight, no, everything when you do it for a reason, and it should make you think in terms of why and what you want to do in patient in terms of investigations. Not just you examine and then you write a big list of investigation, because especially in our setup, lot of patients are unaffording. So you may have to choose which test you want to do at the end of it. And to be a good clinician, you should be able to say, okay, I'm worried about this part, so I will look at this part first, and maybe the other things, HRCT, I can do next time.
Okay, ma'am.
That's the importance. So BP, what does BP tell you in this patient?
Ma'am, since I'm considering a scleroderma as a possibility for this patient, there is a possibility of a scleroderma renal crisis.
Okay.
So,
and you haven't mentioned anything about pallor and other things. Are they important?
Ma'am, I've mentioned pallor.
Okay, pallor. So what does that tell you?
Ma'am, one is the nutritional status of the patient and
so pallor means you are expecting hemoglobin to be low, right?
Yes, ma'am.
So what type of anemia are you going to expect?
Ma'am, anemia of chronic disease. She's had a long history of something which looks like a connective tissue disease. Which
okay. What else? Can it be iron deficiency?
Deficiency as well, ma'am. She can have
because of iron deficiency. Because of
ma'am, gastrointestinal complaints because of losing blood through the GI tract, mainly
okay.
due to it could be due to GAVE also.
What else?
Yeah. Ma'am, there can be some myelosuppression, autoimmune myelosuppression, which can be causing the hemoglobin to be low. Some hemolysis.
Okay. So always your drugs, because she has had azathioprine-induced things. And secondly, simple malnutrition because of bloating, and she's unable to eat.
Yes.
So you will look at that. Okay.
She's had a long.
Do you know how to do a MRSS? Can you tell me the grades of MRSS?
So, ma'am, the modified Rodnan skin score is basically done in 17 areas of the body, and we are supposed to grade the skin thickening into 0 to 3. So these are the various areas that I have demonstrated here. On the upper limb, we have the fingers. That is the beyond the
no, areas you don't explain. Okay. I have seen that. You have mapped that. I want to see how do you say grade 1, grade 2, grade 3.
Okay. So, ma'am, basically we try to oppose our thumb and index finger, and we try to pinch the skin between them. And accordingly, if we are able to pinch the skin between the index and the thumb, and we can see normal wrinkling, it will be 0. If the skin appears to be thickened, and although we are able to pinch it, but there is some thickening, then 1. Um, if we are not able to oppose both of our index and thumb because of the thickening, then 2, and 3 is when we are not able to pinch at all.
And if it is skin has become very thin,
there is a catch there, right? So it's very thin, so especially the dorsum of the hands.
Yes, sir.
Then what will you call that?
In later stages, it can become.
Yeah, it can go into atrophy, right? So
Yes. That is a limitation of the MRSS, I think.
Yeah, next the 6-minute walk test. Do you do it yourself?
Yes, ma'am.
So how do you do it?
Ma'am, basically, we a certain an area for the patient to walk. We first ask the patient to take rest for 10 minutes, and then we explain the procedure to the patient. We designate an area for him to walk, or him or her to walk,
so how do you calculate the area?
Ma'am, number of laps. Basically, we take the number of laps and multiply it by the number of times that the patient was able to go around.
No, basically you have to fix the area. So in your OPD, there must be a lining where how much the patient is going to walk to and fro. And
Yes.
whenever you mention, there has to be a difference pre and post test. That is how you will know the difference. Yeah. Yeah. That's all I wanted to make. And here, what respiratory system, you have said that there was no crepes, na, basically. Yeah.
No
Okay,
added sounds.
fine.
I appreciate
that. You can go ahead.
So investigations. Yes, ma'am. On investigations, the basic labs came back as essentially normal, except that the WBC count was 3100. The neutrophils were 88% and lymphocyte 10. So it was predominantly a lymphopenia. Since she is hypothyroid, we got a TSH which was 7.09, and the urine and creatinine were normal. ESR, inflammatory mark, both of our inflammatory markers were raised. ESR of 74 and CRP of 6.3.
Cutoff of the CRP here?
Yes, sir.
Normal cutoff of the CRP is?
2, sir, in this lab, in our lab, in the lab.
Do you think it's important to know?
The cutoff, yes, sir.
No, the cutoff of the CRP. Why? Is there a role of CRP in scleroderma? We'll discuss that later also. First, you finish with the investigations.
So the immunological investigations, we sent an ANA by immunofluorescence.
Sorry, just go back to the previous slide. You have mentioned the hemoglobin. Do you want to know anything more?
Ma'am, the MCV also we noted that it was 80.
Okay.
So
what does it mean?
Ma'am, iron deficiency anemia is a possibility, but MCV was not that low. So it could be a bicytopenic picture also.
Can this picture be there only in anemia of chronic disease?
Normocytic, normochromic picture can be there, ma'am, in other diseases like myelodysplasia also.
Okay. And low WBC count and lymphopenia. What do you think of that? Why should there be lymphopenia?
Ma'am, this could be due to disease activity or because of the underlying CTD. If the neutrophil count, however, were to be low in this patient, I would have suspected a drug-induced leukopenia.
So WBC is low?
Yes, ma'am. So I thought that the underlying CTD is probably causing the lymphopenia to be there.
Was she on any medication at this stage?
Ma'am, she was taking prednisolone and HCQS when she came to us.
Fair enough.
And she had stopped taking azathioprine in February 2023 because of this leukopenia, but that leukopenia was predominantly neutropenic.
Yeah, you can proceed.
The immunofluorescence that we received, the report that we received was score speckled AC5 3+, 1:100 N dilution, and complement levels were normal. Rheumatoid factor turned out to be positive, anti-CCP negative. ANA blot showed U1-RNP and Rho52 positivity. U1-SN-RNP by ELISA showed titers of more than 240. We did a nail fold capillaroscopy, which showed reduced capillary density, no giant or enlarged loops.
Why did you do C3, C4?
Ma'am, because of leukopenia, we were thinking is this an overlap with the lupus or
And how strongly was rheumatoid arthritis rheumatoid factor positive?
Ma'am, around 100 by latex agglutination. It was a titer of 100.
Okay.
And we wanted to get C3, C4 to be because we were thinking for the investigation of leukopenia mainly, although C3, C4 are mainly they would fall in lupus nephritis more often, but just wanted to make sure. This is the HRCT film that she already had with her, which was done in an outside hospital in April 2023 when she had an episode of low-grade fever, dry cough. So this showed patchy consolidations with cavitatory changes in both upper lobes, left more than right. It also showed tree and bud appearance, and the impression was of an infective etiology, mainly tuberculosis. Apart from this, the HRCT also showed mild interstitial thickening in the bilateral lung parenchyma, predominantly in the peripheral and subpleural aspects, and more in the lower lobes. This suggested a background ILD of NSIP pattern. In HRCT, it was also noted out that there was diffuse dilatation of the esophagus. A baseline echocardiography was done, which showed a mild pulmonary hypertension with a PASP of 33. My final diagnosis after looking at the investigations to a 45-year-old lady who's a known case of hypothyroidism with pulmonary COX, who's currently completed her ATT, which was started in April 2023. She's suffering from mixed connective tissue disease with the organ involvement being Raynaud's phenomenon, polyarthritis, skin thickening, GERD, leukopenia, maybe an early ILD, and mild PH. Currently, she had presented in June 2023 with a flare of arthritis. Should I go ahead?
Sapan, you want to ask?
I was reading what Sanket has written. So 30-meter stretch of an imposed walkway. This is minimum stretch required for 6 minutes walk test usually. Okay, anyway, I think we have only about 4 minutes now. So
yeah, we can take 10 minutes. So because Dr. Shenoy is yet to join, so we can just ask, and then we can just maybe a few minutes on treatment and feedback.
Yeah, I think I would put the diagnosis scotoma, not UNRMP. Okay, antibody positive hai, but you have other antibody also when you have apparent scotoma on examination. I don't know what Shubhada has to say, but I would call this limited scotoma more.
No, I completely agree.
Rather than MCTD. That's number one. So as I told you, I suspected. And don't get into the habit of looking at investigations and basing your diagnosis on this is what all my MDs do all the time. And I know beforehand कि तुमने इसलिए रखा है क्योंकि ये report positive आया है. So don't see that report initially also. And finally, sometimes yeah, we have to change our diagnosis. That happens in rheumatoid when you get a suddenly a CCP positivity. हमने नहीं बनाया है in paranormal rheumatism, but otherwise don't go. I would, when you have such scotomatous changes all over, you could see the photograph of the patient also. Why put in And so that's number one. The other things I agree. The cavitary disease and all was probably tuberculosis, as you said, and background ILD. So what proportion of patients would have ILD when you do HRCTs in these patients?
Sir, about 95% patients
So
have
that's not abnormal. And you will, when they don't have symptoms, if you do an HRCT, you will always find
clinical. Yes,
some,
sir.
some things there.
Yeah.
I don't know if I missed the PFT. Was she able to do PFT?
We are planning to do her PFT on follow-up, sir. We haven't.
And the problem with the PFT is that they're not able to hold and do it properly. It requires. Um, so I don't know. Should we? One of the things was somebody had given azathioprine. I don't know if it was.
Yes.
So what is evidence of azathioprine in scleroderma, and where does it help? Why was it given?
Sir, mainly because of the arthritis, and she had come with outside. She had presented in September. Not able to move my slides.
Oh, that's fine.
That's okay. That's okay.
So do you think azathioprine works well for the joints?
Not as good as methotrexate, sir.
She was given
Was not
methotrexate.
intolerant. She was intolerant to methotrexate because of her GI complaints. So probably as a trial for the lack of another effective therapy, probably azathioprine was tried at that time, but because of leukopenia, that had to be stopped.
Do you think the leukopenia was azathioprine induced or?
Sir, at that time, the leukopenia was mainly neutropenic. So, and it did come back after stopping. So it could at that episode of leukopenia could have been attributed to the azathioprine. But in June 2023, when she presented to us and on follow up also, her platelet, her WBC count was mainly lymphopenic, and that suggested more of a disease activity.
So I feel it was more of disease activity always, right? You have a Rho antibody positive, which suggests that it could be leukopenia. That's often the problem in these patients. पता नहीं लगता है कि azathioprine induced or disease related है. But what I'm trying to say is there's a very little role of azathioprine in scleroderma, right? Especially now with MMF coming in, उसका role तो बहुत ही कम हो गया है. So most rheumatologists would not use azathioprine unless pressed with no other alternative.
The MMF would have not covered her arthritic symptoms. That is why probably.
Yeah, that will still not cover. Yeah, but because the lung part, most of us have now shifted to.
Right.
So yeah, I don't know, Shobhada, maybe the treatment you can ask.
Yeah, we can ask her to go with the treatment.
I'm not able to move my slide. Just a second, sir.
I'm sure you can just tell what you gave,
Yes, ma'am.
Yeah, it opened.
Yeah.
In view of refractory inflammatory polyarthritis and persistently deteriorating leukopenia, despite 1 milligram per kg of corticosteroids that we gave her, and we tried 3 doses of injection filgrastim as well, but the leukopenia persisted. We did a bone marrow aspiration also for this patient in subsequent admission, and that showed a myeloid arrest. So ultimately, she received 2 doses of rituximab, 1 gram, 15 days apart in June 2023, and corticoid in tapering dose, glucocorticoid in tapering doses, along with HCQS. For her GI symptoms, we had given her proton pump inhibitors and a domperidone. And for Raynaud's, we advised her to avoid cold exposure and vasodilators. Both of nifedipine and tadalafil were started, and thyroxine was continued at 50. On a follow-up a week ago, on the 5th of October, she had come back for follow-up, and she currently did not have any swollen or tender joints. She was relatively doing better, and MRSS score initially in June 2023 was 19. When I did the MRSS again, the skin had become a little soft and it was 15. Her GERD symptoms were better and her WBC count had also normalized, currently 6100. That's it, sir.
Yeah, I think we have the big boss has joined. So maybe 1 or 2 things. I'm not sure why you should try 1 milligram per kg prednisone in such patients. We all know that they are, this is not diffuse, but they can still go into scleroderma renal crisis. Again, something more theoretical, ज़्यादा देखा नहीं है. Lekin, I don't know if that was needed. Maybe, and rituximab is fine because you don't have, usually we look for something else before giving rituximab. I would look for maybe some ILD or something else, or try lesser drugs for just the joint pains in these patients. But that's fine. You can give rituximab, and the fact that she's improved. I would want you to know the evidence of rituximab and scleroderma in various conditions. Maybe you can go through that. We don't have the time because Shenoy is around. Shenoy is already there. The one thing I would like to ask you is, if you see myeloid arrest in
Yes.
such reports, do you think of something else in recent times? She's a female, of course, but yesterday Shenoy and I had a discussion. It was this topic. Maybe he can. So it's time we started doing cytogenetics in these patients, in those who can afford. You might find something there in these patients, right? They evolve into various things. I hope Shenoy will cover that in his talk. Anything, Shubhada, you have?
No, I think you have covered the most of. If patient cannot afford rituximab, what else can you try? Do you want to think about that?
Ma'am, since she also had a underlying tuberculosis treatment ongoing, and TNF inhibitors have not shown too much promise with.
No, patient cannot afford rituximab. So the question of TNF doesn't come.
Okay, yes, ma'am. MMF wouldn't cover the arthritic part, but
fair enough. What else? That would cover arthritis and cytopenia.
Cyclophosphamide, but then again,
myeloid arrest you cannot use, no?
Yes, leukopenia was there.
So usually in scleroderma, we don't use cyclosporin because we are worried about renal thing and hypertension. But here, possibly to bring up the count, sometimes you can. And now tofacitinib is also coming in few studies. So if you are pushed to the wall or patient is sensitive to rituximab or something, these are some of the options to use.
Okay.
Okay, just one short feedback for her, then we'll proceed to the next session. Dr. Sapan, feedback about her presentation.
It was a good presentation, very good. In fact, I think this is a great chance for. I always thought कि ये सब bedside ही ज़्यादा अपनी generation bedside ज़्यादा किया है तो वो bedside का एक bias रहता है. But I think it was during COVID we did this with some of our own, and I think it's very good. And the only thing is that maybe the what we say should be open to all, because just because I say it doesn't mean that it is right, and maybe people can comment on if I may be going wrong, or there are other suggestions. We could have those and compile those and share with each other. It's a learning for everyone, not just for the great.
Absolutely, including us.
Dr. Shubda?
Yeah, she presented very well, I think. So few just points which we told you. You need to be very sure about this, and basic his clinical examination. There is no one will forgive you for making a mistake there. Anything else in treatment here, there, everything is fine. But basic history and clinical examination should be perfect for you to do well in the exams. That's just the message. But you did well.
Thank you, ma'am.
You had prepared well. So
Akansha, stop sharing the slides. Yeah. Thank you so much, Dr. Sapan, Dr. Shubda, for sparing so much time on a Sunday morning. Really thankful to both of you.
It's a pleasure. Thank you, Kavita.
Hope to have you again on this forum. We now also welcome Dr. Padmanabha Shenoy. He is a well-known personality in rheumatology, and all of you know each other so well, but I would just take, it's my privilege to introduce. Dr. Padmanabha Shenoy is the medical director, consultant rheumatologist at Center for Arthritis and Rheumatism Excellence in Kochi. He's also the consultant rheumatologist at Sri Sudhidra Medical Mission. He was the first one to start DNB rheumatology in the state of Kerala. He's an alumni of SGPGI Lucknow. He's currently the honorary treasurer of IRA at present. He's got so many publications, awards to his credit. There's so many projects that he's undertaken and ongoing. He presents at the ACR. So one of his favorite topics is CTD-ILD. So today he shall be talking on management of CTD-ILD. I welcome you, Dr. Shenoy, on behalf of Maharashtra Rheumatology Association. Over to you, sir.
Thank you, ma'am. Thank you, ma'am, for the kind invitation and the kind words. So straight away, let me start the topic. So CTD-ILD, I have been interested in CTD-ILD for some 10 to 12 years now. From the DM program, I was interested in scleroderma primarily. Then CTD-ILD has seen large amount of literature coming up. The way we manage CTD-ILD has seen a sea change. So it's a pleasure. Thank you for giving me this topic, and thank you for the kind invitation for the this opportunity to talk to you guys. So whenever a CTD-ILD, this slide, I love this slide. This is a paper which was published 10-15 years back in American Journal of Medicine, showing that a huge number of scleroderma patients, 3,000 patients, 20,000 patient years, long-term follow-up, shows that the 5-year mortality of scleroderma is around 40%. We have our own registry running now for around 800, 900 patients across country, 900 patients. When we just saw the data, 2-year data, the mortality is 12%. So scleroderma is a killer disease. But the problem is that we are scared of Hodgkin's, we are scared of colon cancer. But when a scleroderma patient walks to your room, we don't have that sense of urgency, which I think we need to change. When a scleroderma patient walks into your room, we are not looking at a disease which is very mild, which will cause some skin thickening and deformity. No, it's a killer disease and 40% chance of 5-year mortality. Even SMR is 5 to 7, standardized mortality ratio, means they are likely to die 7 times more than the population, even highest among CTDs. And lupus nephritis is the only thing which has a CTD which is close to the scleroderma, and it is only 2, just 1/3 of scleroderma. So scleroderma is a killer disease, no doubt about it. So when you look at USTAR database, this is one of the largest studies of 5,000 or 6,000 patients in Europe, different countries. When they analyzed the scleroderma death ratio, they had around 234 deaths, and out of which around half of them because of pulmonary fibrosis. So the major cause of death in scleroderma is lung and related complication and pulmonary artery hypertension. If you look at, so first, scleroderma kills. Second, in scleroderma, the death happens due to lungs, and in lungs, the death is predominantly in those patients who have less FVC, low forced vessel capacity. If you can see here, those people who are FVC is less than 80%, the chance of death is around 25 to 30% at 3 years. So there is no doubt that we have to screen interstitial lung disease in not only in scleroderma or scleroderma spectrum disease, MCTD and others. So how do we screen? How useful is PFT in screening? PFT is the one thing we use commonly day in and day out. So if this is one study which was published in Arthritis and Rheumatism in 2015, they took 100 patients with scleroderma, 64 had interstitial lung disease on HRCT. HRCT is the gold standard. Of these 64 patients, only 24 had FVC less than 70%. So only 1/3, almost 1/3, less than 50% had FVC less than 70%. If by FVC less than 70%, that is the cutoff all of us take. So fine. So so sensitivity of FVC is only 60%. If you see the FVC less than 80%, even DLCO include, the maximum sensitivity you can get is 60%. If you take only less than 80%, the sensitivity is around 35 to 40%, indicating that it is not at all a sensitive technique. If you combine with DLCO, you get a 60% sensitivity. That also is not great. So FVC has a very poor sensitivity. So the question people think, okay, you have an FVC of the slight mild ILD in CT. What are you going to do about it? Just ignore it. What the problem is that of the 40 patients with a normal FVC value, 5 of them had severe lung fibrosis. And 2 of these patients, result of all PFTs were within normal limits. So PFT can miss even severe cases. Please drive it into your mind. PFT can miss even severe cases. So we should not use pulmonary function test to screen interstitial lung disease for the first time. When a patient comes to you with scleroderma, PFT is not the best test or not the appropriate test for ruling out interstitial lung disease because it is not sensitive. We have to use, for lupus ruling out, we use ANA. Why? ANA is very sensitive. In pulmonary function test, is not sensitive, so we should not use it. So this brings us to our second investigation, which is very, very useful, which is HRCT. HRCT is a must in every scleroderma patient. It's a very sensitive and very specific. Only problem is that we have to do it properly. So how do you do HRCT properly? This is one thing I have learned over time, and is that you have to do HRCT in full inspiration. See this, the top one is in expiration and below one is in inspiration. If you look at the top top CT, you will very clearly see you will think that there is a ground glass opacity and early interstitial lung disease in this patient. But if it is repeated in the full inspiration, it is completely cleared. So you should know whether the CT is done in full inspiration, or how do you know how to differentiate between inspiratory image and expiratory image? It's very clear, very simple. If you look at the trachea, see this trachea is round here in inspiratory image. In expiratory image, there is a convex. The posterior border is convex. So always look at the trachea to see whether this is inspiratory image or expiratory image. So be very careful. If it's expiratory image, ask your technician to repeat a CT in a full inspiratory image. And second most important thing is prone image. For example, you must have seen a lot of patients with scleroderma. You do a CT, the radiologist reports early interstitial lung disease. Whenever you have an early interstitial lung disease, where there are some shadows, basal shadows, you repeat the CT in the prone position. The moment you make the patient the prone and repeat the CT, suddenly the entire shadow disappears. Entire ground glass opacity disappears. Basically, it was basal atelectasis. So whenever you are supine for a long time, you may get some basal atelectasis, but the moment you make them prone, it disappears. So second thing, full inspiration is first. Second, in early interstitial lung disease, always do prone. And this is one of the CTs which usually all of us see 30 images in a single film. No, always try to do, you have less number of films, maximum is 16. Always try to do C in packs or get a CD and C, because that makes a hell of a difference. So CT has to be done in all cases. How should you do? You should do in full inspiration, breath hold, and always never forget to look whether the image is inspiratory or expiratory. And in selected cases, always you do a prone image also. So now we have done a CT. So what should you understand? Whether the patient has an NSIP or UIP. All of you know what is NSIP and UIP. I don't want to go into details of that. Just reminding you how to differentiate between NSIP and UIP. This is for beginners. In NSIP people, there will be subpleural sparing. You can see here, the area which is just beneath the pleura is spared. And there is a lot of ground glass opacity, which we call mosaic pattern. When you see UIP, there is no subpleural sparing and there will be lot of honeycombing. So NSIP will have ground glass opacity and subpleural sparing. UIP will have no subpleural disease and there will be lot of honeycombing. And when a patient comes to you, this is another common scenario. Your pulmonologist refers to you, this patient, whether the patient has associated CTD or not. If a pulmonologist refers to you with a patient with exuberant honeycombing with more than 70% lung involvement, the most likely the patient has CTD-ILD than IPF. Or second very important sign is straight edge sign. If the edge is straight, suddenly at a single point, it abruptly stops. And above that, the lung is normal. Below that is lung is involved. That is called straight edge sign. If you have these two signs, the chance that the patient has CTD-ILD over idiopathic pulmonary fibrosis is very high. So you have to very carefully look for all the markers. So till now I have told you how to diagnose scleroderma ILD, how to differentiate between NSIP and UIP. So how to treat? This is the most important thing. Stratification of scleroderma ILD is the single most important thing to note, because not every scleroderma interstitial lung disease progress. In rheumatoid arthritis, if seropositive, most of them progress, we know. In lupus nephritis, if somebody has a class 3 or class 4 nephritis, they progress, we know. But in scleroderma ILD, it is not that every scleroderma ILD progresses. But so we need to treat those who progress. Or in other words, treat those who are at high risk of progression. Either you wait for progression, and if they progress, you treat. And otherwise, more intelligent people will understand we will try to make sure that whether the patient is going to progress or not. And if the patient is progressing, we will treat. So these are the questions that we have already answered. Whom to screen? We need to screen all. How to screen? We have told HRCT. How to diagnose? I have already told. And treat. Should we treat everyone? That is the question. The answer I already told. We should not treat everyone. We should risk stratify. And second thing, which another very, very important point as a rheumatologist we need to understand is that in scleroderma ILD, be it CTD-ILD, be it NSIP or UIP, doesn't really matter. If you treat well, both NSIP and UIP respond almost equally well. Only difference is that in UIP, because the fibrotic disease, maybe antifibrotics like nintedanib may be more useful. I was telling you, treat those who progress. And what is progression? Progression is, I would appreciate if everybody is keeping it mute, please. Excuse me.
Prasad, please mute everybody. Prasad, please mute everybody.
Yes, ma'am. Yes,
Yeah.
ma'am.
Yeah.
Sorry, sir. Carry on. Yeah.
Yeah. So we need to treat those who progress. So we.
Yeah. I think Dr. Shenoy, unmute yourself.
I unmute. Yeah, I unmute.
And others are muted.
Yeah. Done. Thank you, ma'am. So treat those who progress. What is progression? Progression means there is basically, we need to understand that if it's called composite categorical decline. This is a very, very important concept. If somebody develops a decrease in FVC more than 10% or dip in FVC more than 5% with a DLCO dip more than 15%, that is called as composite categorical decline. So let us take an example. If somebody has 60% post-vital capacity, he comes back to you with 10% decline, means it becomes 54. So from 60 to 54, that is 6%. 6% 6 is 10% of 60. So if there is 10% dip, you need to be really vigilant. Why? The chance of death of this person, you can see at the end of 10 years is 20% survival, 80% chance of death. If somebody's lung volume has lost within 1 year, more than 10%, you have to be really, really careful and you have to treat them very, very aggressively. So this is called composite categorical decline. Rule of thumb is 10% decline FVC over 1 year is very, very significant. But the problem is that waiting for progression is allowing the lung to destroy. So we cannot wait for progression, right? Do you think in MI we wait for the ejection fraction to decrease? No. In RA, do we wait the erosion to appear? No. That is an old concept. So what do? We need to identify those factors which are high risk for progression. One of which is early years. This is Virginia Steen's age-old paper, which I love, which says very clearly that serial PFT, if the pulmonary function test loss or lung volume loss happens early during the first 4 or 5 years. Serial PFT after first 6 years, rate of loss is 6%, 5% per year. After 5 or 6 years, the lung volume loss gradually comes down. So identify them early. And if they have, if a scleroderma patient presents to you with early, even if they have mild ILD, treat it very aggressively. And second more important point is antibodies. This is, I have taken this slide from Professor Dinesh Khanna. You can see here, this shows the prevalence of interstitial lung disease with each antibodies. And no marks for guessing, anti-SCL70 antibody has the highest amount of, see, look at this green one. This green one is anti-SCL70. Anti-SCL70 or anti-topoisomerase 1 antibody has a 75 to 80% risk of extensive pulmonary fibrosis at the after 5 or 10 years. So second learning point of today is, it is not the type of scleroderma matters. Previously, what we were taught? We were taught that limited scleroderma does not have ILD and diffuse scleroderma has interstitial lung disease. That concept is changing now. Even limited scleroderma, if the patient has anti-topoisomerase antibody, they are likely to have progress. So what is more important? Not the type of scleroderma, it is antibody which is important. If you look at the bottom chart, if you have anti-centromere antibody, the chance of progression is chance of development of ILD is very, very low. So look at the antibodies, second point. So can we identify those at high risk of progression? As I told you, two major issues. One is early disease, they progress. SCL70 positive, they progress. Low FVC at presentation. If somebody has a low FVC, less than 70% at initial visit, they are high likely to progress. And more than 20% lung volume involved. At the CTUC, within 2 years, 20% lung volume is involved. They are likely to progress. These are definitive signs. More importantly, other factors you need to consider. If somebody, a 70-year-old scleroderma comes to you, the duration of disease is around 15 years. You may not be very aggressive. But if somebody is 25-year-old young girl comes to you, FVC is 55%, you will treat her because she has a long life ahead. And comorbidity, if somebody has CKD, you know already the outcome is pretty bad. You won't go that aggressive. And last but not the least, lung volume at presentation. If somebody's lung volume is 20% at presentation, it's almost a burnt out disease. If you very aggressively immunosuppress them, they get a minor infection and they succumb. So you have to be careful. It's a lot of art is involved in managing scleroderma interstitial lung disease than science. And a very, very important point, which I earlier also mentioned, type of ILD doesn't really matter. Be it NSIP, be it UIP, is not the primary concern. It has to be, these are the factors, other factors are more important than this. So what are the drugs which we have? When I started working in scleroderma, there were nothing. Basically, we had debates in SCPJ whether really we should treat this disease because we don't have much drugs. There was steroids, cyclophosphamide, done. But in 2020, there's a lot of drugs are coming, and I'm sure we ourselves are involved in 2 or 3 major clinical trials with new drugs. Steroids is there, cyclophosphamide, mycophenolate, interleukin-6 blockade, anti-B cell therapy, tofacitinib, nintedanib, and newer molecules. A lot of molecules are in pipeline. So it's a exciting time to work in this disease because now the entire management conundrum is changing. The most useful drug, mycophenolate and cyclophosphamide. These are two large. This is one of the largest study, SLS2 study, randomized control trial, where Dr. Dinesh and their colleagues compared 1 year of cyclophosphamide vis-a-vis 2 years of mycophenolate, and you can see here in both the groups, the FVC improved to great extent, to 5 to 7% improvement. On the left-hand side, this is our retrospective study published in 2016. We had published this in Arteries Research and Therapy, again showing that both the groups showed improvement in FVC. So previously what we thought, fibrosis does not improve. So improvement in FVC not possible. That is burst 5 or 6 years back. Improvement in FVC is the norm in majority of patients. It happens, we give mycophenolate, we give cyclophosphamide, improvement happens in majority of patients. So, but mycophenolate is slightly better tolerated, but cyclophosphamide is cheaper. So depending on your situation, definitely you can give whichever way you want to give. And but always we have just published one of our papers, randomized control trials, again a crossover trial of mycophenolate versus mycophenolate sodium, and what is the effect of giving pantoprazole or ranitidine to these patients. We should very clearly understand the moment you give ranitidine or pantoprazole, it decreases the drug level by 50%. So with MMF, you give always a empty stomach. So, but some of the patients have GERD. So the way forward is switch to sodium salt, mycophenolate sodium salt. So never combine PPI with mycophenolate. This is one of the major reasons. Improper drug intake is the major reason for drug failure of mycophenolate. So mycophenolate and cyclophosphamide are the first line drugs. Once you give them, you can see here 30% in either in mycophenolate or cyclophosphamide, they don't work. So what do? The first and foremost is switch. Those people who have been treated with mycophenolate, try giving cyclophosphamide or vice versa. Other two options are, one is rituximab and third is hematopoietic stem cell transplantation. So this is from Dr. Parash's groups from Calcutta. This is published 5-6 years back. They compared intravenous cyclophosphamide vis-a-vis rituximab for early diffuse scleroderma. And as you can see, what happened here, rituximab improved FVC, but cyclo stabilized it. And you can see the in all the domains, be it forced vital capacity, modified Rodnance, and 6-minute walk distance, rituximab was slightly better when compared to cyclophosphamide. And there is a meta-analysis which has come up, which was published last couple of years back, where they could show us that FVC improved after giving rituximab. FVC improved by 7% by 1 year in those patients who were treated with rituximab. So again, improvement in FVC has happened in a lot of patients. And this is a very recent trial which was published, Recital trial from UK, but they had a heterogeneous population. They have recruited around 100 patients which prematurely closed because they couldn't recruit enough number of patients. They took 100 patients, out of 50 were given cyclophosphamide, 50 were given rituximab, and what happened was that around about 50% of their patients had myositis. So and other 50% were scleroderma MCTD spectrum. So there was a mixed cohort. And half of them were given cyclophosphamide, half of them were given rituximab. And as you can see here, what happened in the both groups, the FVC again improved, but there was no difference between cyclophosphamide and rituximab. So there was around 200-300 ml of improvement in FVC in both the arms. So this study, Recital study, showed that in the CTD ILD or predominantly myositis spectrum, they have taken half of them, they could show that rituximab is equal to cyclophosphamide. Then coming to interleukin-6 blockade, tocilizumab is a new kid on the block in scleroderma. This is a focus trial. They have taken 210 patients, randomized into tocilizumab vis-a-vis placebo. You can see here, tocilizumab stabilized forced vital capacity, while in placebo arm, it dipped to a great extent. You can see the loss of lung volume in the placebo arm. So the message here was very simple. Tocilizumab stabilized lung function in early disease. And also there was less treatment failure with tocilizumab when compared to placebo. Then what they do after 48 weeks, what they do in the blue arm, the lower one is basically nothing but the placebo arm, and the orange one on the top is tocilizumab. After 48 weeks, they switched over the placebo arm to tocilizumab, or those who were on placebo till 48 weeks were given tocilizumab. The moment they were given tocilizumab, as you can see, the blue line is dipping. After 48 weeks, suddenly it stabilized, indicating even slightly later disease also, tocilizumab stabilizes lung function. Adverse event, the major adverse event of tocilizumab, as all of us know, is infection and cardiovascular disease risk, CVD risk, but infection is a major risk. So tocilizumab, in my practice, I don't use upfront scleroderma, although some people use. I use only in patients who are having very early scleroderma with a very high CRP, inflammatory marker. These are the patients where tocilizumab may be considered. And another very newer mode of therapy is nintedanib. Again, in the market, in India, it is there for last 4 or 5 years. It has become really cheap. So we have been using in a lot of patients now. Initially, their tolerance was bad, but now we also have learned how to use this molecule, give a lower dose, slowly up titrate. Nintedanib people are able to tolerate. And you can see here, nintedanib vis-a-vis placebo. This is a large trial, which was again a New England Journal trial published in 2019. You can see those patients on nintedanib, they had a less lung volume loss when compared to placebo. So those patients with placebo lost around 100 ml per year, while those who are on nintedanib lost only 20 to 30 ml. So there is a significantly less lung volume loss with nintedanib. But my interest, this is a sub-study of Senesis trial, where what they have done is they have compared the group where mycophenolate plus nintedanib with neither mycophenolate nor nintedanib. So if you see here, those patients with mycophenolate in nintedanib lost only 40 ml per year, vis-a-vis those patients who not taking neither mycophenolate, neither nintedanib, they lost around 120 ml. So the difference is around 80 ml per year, or 5% of FVC. So that is a huge amount of lung volume to lose per year. So I think the future is going to be mycophenolate with nintedanib, maybe the future. This is a famous court trial. Again, role of hematopoietic stem cell transplantation in scleroderma, very clearly showing that those patients who transplanted had a much better lung volumes at the end of 5 or 6 years when compared to those who are on cyclophosphamide. So it's a clear winner. Transplantation is much better. And if you look at the FVC improvements are much better in those who were transplanted. So is this the end of immunosuppression in scleroderma? The answer is no. This is our rebuttal, which we wrote as a letter to editor, which was published in a New England Journal. But the reason for one of the reasons for low FVC in cyclophosphamide arm is there was no proper maintenance given in cyclophosphamide arm. So they have not compared proper long-term immunosuppression vis-a-vis transplantation. We know that transplantation has a long-lasting immunosuppression effect, but cyclophosphamide don't have that. And if you look at this chart very carefully, the difference appeared around 2 years. 2 years only the difference appeared. The 1 year the cyclophosphamide given, after the 1 year, 1 more year the effect will last. After that, cyclophosphamide effect will wean off. So the difference in this study was probably because of the lack of long-term immunosuppression in the cyclophosphamide arm. And this is the latest one, CAR T-cell therapy, again published in ARD last 2 months back. What they have shown, if you give CAR T-cell therapy, I think this is one of the promising therapies which we are going to see in every rheumatic disease where rituximab is effective. And CAR T-cell is going to come in India in a couple of 2-3 years or so. What they could show was that lung skin improved, lung volume improved, and also if you see here, even the antibodies became totally negative. So that's I think this is one of the areas which I think as a rheumatologist, we need to learn now, CAR T-cell therapy and genetics, and how these therapies are evolving very fast. So I have told whatever the drugs we have in the armamentarium, how to use these drugs. So first we have to set a target. Let's be very clear about this. We need to treat this patient to target. What is a target? It is stabilization or absence of progression. So what is stabilization? What does progression means? Progression means FVC fall more than 10%. As I told you earlier, if somebody has 70% lung volume FVC, if it becomes 63, it is significant. I usually do pulmonary function test in early disease every 6 monthly. And even if there is 4 to 5% dip in 6 months, I take it very, very significant if the effort is good. But the most important point is at your center, you should have a standardized PFT. It is impossible to manage or should not manage a scleroderma interstitial lung disease without having a proper pulmonary function test. It has to be standardized. Inter-observer and intra-observer variability has to be less than 2%, 2 to 3%. If it is more than that, never do. Another very useful tip I learned last week was, if you do a pulmonary function test in the morning, the lung volumes are higher. If you do in the afternoon, it is 3 to 4% lower. So try to standardize your pulmonary function test and do at the same time of every day. This is a new thing. I think it will be very useful because we are trying to titrate based on pulmonary function test. So if you see FVC 70, next time we have done a standardized pulmonary function test, FVC has fallen by more than 10%, it has become by 67 or 62. Document the progression by CT also. And if that is there, that is called as progression. So if somebody, a patient comes to you, you start on mycophenolate or rituximab is the first line drug. What I use, mycophenolate most of the time is the first line drug. If the patient is stabilized, I go to the maintenance phase. Maintenance phase, either continue the same dose of slightly lower dose of mycophenolate, and if they are stabilized, I continue. If they maintain on the maintenance phase, if they progress, switch back to the original therapy or hike up the dose. But there are some patients of mycophenolate or rituximab, they progress. So what do? You switch or change to cyclophosphamide or add nintedanib. So this happens around 20 to 25% of the patients. 75% takes this route and 25% comes to this route. And early disease, maybe you can use tocilizumab, and a very refractory disease, maybe because with MDF5 and use in fibrotic diseases or inflammatory lung diseases in antisynthetase and myositis, maybe tofacitinib also may come up in a way in the coming years. And we have very clearly shown, this is our own data again, very clearly showing that those patients who are on maintenance, they do much better. Those who don't default and stop treatment, there's a very high chance of mortality. So you need to maintain them. How long? Minimum 5 years. I would say in scleroderma interstitial and lung disease, better to maintain a very low dose for long term. Better not to stop. So I have told you what has to be done. So I will just give you some case scenarios. This is a 38-year-old female. She presented to us because she went to a dentist. The dentist told that she has loose teeth. Rheumatology consulted her. She came to us for microstomia. She had diffuse scleroderma. SCL70 is positive. FVC is 98%. This is a CT. What does the CT show? There is a early NSIP pattern. There is subpleural sparing. There is an early NSIP. Will you treat? The answer is yes. Because maximum volume loss happens early disease and highest volume loss happens in SCL70. Despite having normal FVC, CT showing ILD in SCL70 positive, I will treat. What we like to use? Either mycophenolate or rituximab. Second case scenario, 54-year-old female, Raynaud's for 15 years. She has a long-standing limited scleroderma. She is really breathless. Grade 3, MMRC 4, grade 3 MMRC for 4 years. And SCL70 is positive with FVC of 43%. Look at this, extensive UIP. Will I treat? The answer is yes. With what? Mycophenolate with nintedanib. Why nintedanib? Because there is a lot of UIP, a lot of fibrosis going on. So he points not here. Limited scleroderma also can have SCL70 positivity. Limited scleroderma also can have severe interstitial lung disease. Another patient, 41-year-old female, Raynaud's, pitching scars, limited scleroderma, and history of dry cough, grade 3 dyspnea for 1 month. Infective workup is negative. What does this show? Can you tell me this? Any postgraduates? No.
Unmute yourself and answer. Yeah.
Sorry?
I'm just telling the students can unmute themselves.
Yeah. Students can answer.
GGOs and NSIP, sir.
No. This is BOP.
Both.
COP. Previously used to cause BOP. Now it's COP. Cryptogenic organizing pneumonia. Extensive consolidation. Infective workup is negative. This is one of the diseases where we give steroids. You gave higher dose of steroids. Scleroderma, usually you don't give higher dose of steroid. Rare condition is ILD COP. It's described. It's a very rare disease. Another case, 34-year-old female, NSIP, on mycophenolate for 2 years. FVC improved from 75 to 85. So if you look at 2 CTs, see this. The 2019 had ILD here, which has really come down. What will I do? I will taper mycophenolate. This is another scenario. Usually I don't repeat CT in a routine practice, but this is a CT was done for some other cause, that's why I taken. But for more confidence, we can taper. After 4 or 5 years, you can do a repeat CT and see how they are doing. 48-year-old female, SCL70 positive scleroderma on mycophenolate. What happened? FVCs dipped 60 to 52% in 1 year. So almost 13% dip. Very high mortality. I have already told. You can see here. This 2020, 2022. See the progression. Extensive progression, right? So what will you do? I usually add rituximab to mycophenolate, or another option is changing to cyclophosphamide. And this is another case, 33-year-old scleroderma on mycophenolate presented with new onset cough and breathlessness. So what does she has? You can see here, this is 2016 CT, this is 2018. In the upper zone, there is new infiltrates. So what is this? Any postgraduate?
Yes, Dipti Shri can answer. Akansha.
This is nothing but tuberculosis. The patient turned out to be tuberculosis. So never forget to think of tuberculosis. I have seen 4 or 5 patients. We will delay the diagnosis. Why? They will complain of cough. Cough is maybe probably because of this. We will delay diagnosis of sputum AFib. So keep checking sputum AFib. If they are complaining of long-term cough, it doesn't lose. You don't lose anything. I think this is one of the last patients. 20-year-old female, non-case of SCL70 scleroderma. She has breathlessness, not on treatment. What is there here? Apart from NSIP pattern, there are large bullae. Can you see? Lot of emphysematous bullae. So diagnosis here is NSIP plus emphysema. It is called combined pulmonary fibrosis emphysema or CPFE syndrome. It's a rare disease to happen in scleroderma, but it's called CPFE. It's a poor prognosis than CTD, and they have higher prevalence of pulmonary hypertension and lung cancer. So food for thought is very clear. All of you are going to have lunch. Before having lunch, think of this. Disease of scleroderma is deadly if untreated. We have reasonably good investigation which are highly underutilized. I keep seeing a lot of rheumatologists, even they have not done well, they manage rheumatoid arthritis, they manage lupus well. But when come to scleroderma, they don't do pulmonary function tests, they don't underuse HRCTs. The diagnosis of ILD is very much delayed. Let's change it. We have drugs which is highly effective in close to 90%. Evidence has emerged over last decade, but underdosing is again very highly prevalent. And people don't switch. People start on mycophenolate and maintain on mycophenolate without looking at lung FVCs. And monitoring tools are available, but the problem is no target is set. And we need to set one. And I think that the easiest target is stabilization of FVC. And treat to target, stabilize FVC, preserve lung, and prevent death in scleroderma patients. This is my team. Thank you for patient listening.
Thank you so much, Dr. Shenoy. That's an excellent talk. So we just have some questions in chat box. Can you take for a few minutes?
Yeah, please, ma'am.
So one of them is by Dr. Sri Lakshmi. She said, as you said, we should not give PPIs with mycophenolate mofetil, but many patients do not tolerate mycophenolate.
Which one, ma'am? Mycophenolate?
MMF, yeah.
So I think it's very clear. You give mycophenolate sodium salt.
Sodium salt.
Sodium salt, yeah.
And the other question is how frequently you combine mycophenolate mofetil with rituximab? Do you give
it
both?
Happens. I only give combined patients only when they are refractory. So it's a norm. I think somebody is progressing in mycophenolate. I think I combine rituximab. That's very good, very effective. But only thing is you should not combine everyone. For example, if somebody comes with a diffuse disease, SCL70 positive, have a diffuse disease already. If you look at the skin score is more than 30, 40. Give rituximab because rituximab plus mycophenolate is one of the most potent therapies. And even if there's cyclophosphamide is also works very well. Those patients whom I have treated in 2010, the skin score is 0. They do extremely well. If you catch them early and give them cyclophosphamide or rituximab or mycophenolate for that matter. So the choice of therapy is empirical, but the problem is monitoring. You have to really monitor them and then adjust the therapy.
So when you start one treatment, when do you say it's refractory and you change? How long do you wait?
3 to 6 months, ma'am. 3 to 6 months.
3 to 6 months. What proportion of SCL70 positive patients will not progress? Are there any of the markers, or should you just see the markers, or a holistic approach is required?
we have to treat SCL. See, this is not that every patient of SCL70 is going to progress. As I told you, 75 to 80% of them progress. So how can we, this there's a KL marker, KL7, we don't do it. That is one marker people use. Those who are having an early disease, for example, somebody SCL70, 2 years, has an early ILD, they are likely to progress. But somebody is SCL70, they have a minimal ILD, even after 20 years, they are unlikely to progress. So there is no definite rules who will progress. We don't have a biomarkers, but by and large, SCL70 patients progress and they develop interstitial lung disease.
Can tocilizumab have a role in any other CTD, ILD other than early scleroderma?
We don't have evidence as of now, but tocilizumab, having said that, interleukin 6 is an important cytokine. It may have, but evidence is still yet lacking.
And regarding autologous stem cell transplantation, what is your experience, sir?
I have not used, because what I think is majority of the patient of scleroderma interstitial lung disease, majority, if you treat well with immunosuppression, with long-term immunosuppression, they do well. For example, I will tell you, we have around 250 patients of scleroderma cohort now, out of which after 6 years, we have 10 or 12 deaths. So that indicates 95% survival or more than 95, 96, 98% survival. So, but you have to be really passionate about managing the disease, because I think scleroderma is one of the most difficult diseases to manage. There are multiple domains which we need to look at, and there are a lot of other social factors we need to address. It's one of the most difficult diseases. Not lupus may be inflammatory disease. After inflammation settles down, they settle. ANCA-associated vasculitis is a bomb. The moment they settle for long, well and good. But in scleroderma, it's not like that. You have to be really. I always say lupus is a 100-meter race, or vasculitis is a 100-meter race. Always, but scleroderma is a marathon. You have to run with them and help them. Yeah.
When should we start antifibrotics?
Antifibrotics, I usually start when somebody has a UAP pattern on mycophyllate, patient progresses. That is the time I usually start.
There's some studies that the quality of life really improved. Like you showed, the FVC decline was not there when we used the combination. But when we have these QOL scores, they were not really significant.
Very true. Yeah.
Okay. HRCT does a better job at screening or PFT? Because many patients can't perform the PFT. As you said, the standardized PFTs are not available many a times. And how frequently you would recommend an HRCT?
So, but I think, ma'am, we have to have a FVC, PFT, ma'am. See, initially what happens is, in our clinic, we have a scleroderma clinic every Saturday. So every Saturday, we have 2 technicians who have been very well trained. And they don't take an answer for no. They sit with the patient, make the patient perform a PFT. What happens is, those people who are sitting in pulmonology labs, under pulmonary departments, they won't be that persistent. They will say, okay, you are, because in their asthma patients will perform it very fast. Scleroderma patients requires a different kind of approach. They need some pampering. Then only they will do. But once they will do, most of them, 95% of my patients are able to do pulmonary function test after, and you have to take repeated readings. Yeah, but they are able to do. And CT for all, the problem is CT is a structural scoring, and if PFT is a functional scoring. And always we need to look at functional scoring than structural scoring. For almost that correlates better with long-term outcomes. And another very useful tool which I have learned last 3 years: do 6 minutes walk distance at each visit. The patients will surprise you, because one of the first signs of progression or severe disease is they walk 6 minutes. 6-minute walk distance comes down gradually. They used to walk 350 meters, 400 meters, suddenly 330, 250. Then 250, they develop desaturation. What do you call desaturation? 95, it becomes 90 at the end of 6 minutes. So these subtle clues you pick up and you manage them, micromanage them, usually they do well.
Patients who cannot afford rituximab, tocilizumab, and not responding to mycophenolate mofetil or cyclophosphamide, would you give tofacitinib or anything else? Have you tried?
We can try. Tofacitinib, the data is very limited. Definitely, because there's scleroderma rheumatoid arthritis overlap. I have tried in 3 or 4 patients. It works well, but it's too early to say. But tofacitinib is worth trying. But there is a study from SGPGI recently they have conducted, and they have shown that a lot of patients develop tuberculosis.
Any other drugs? Any other drugs, would they be useful?
Tacrolimus is another drug which may be useful. Tacrolimus.
Okay. There's a question by Dr. Sanket Shah. As pointed out, HRCT does a better job in screening, and our monitoring is more PFT based as we treat. Would biomarkers help?
Very true, very true. Biomarkers will help, but only thing I told you, these biomarkers, one is this not very standardized. Things are not available. One is KL6 is one of the biomarkers which is coming up in a big way, but again, the correlation is not perfect. KL6 is one of the things which is coming up. Maybe it will come up, but they have tried a lot of stuff, but nothing hold a very high promise.
Any other questions for anybody? You can unmute yourself.
Akansha has asked ultrasound for ILD. It is people are looking at it, sir, again. Looking at the K lines and thickness of the picking up early ILD, but I think more research is required in this area, and maybe in coming years we will have more data.
Yeah, I think Command Hospital.
Namisha's husband actually, Dharmesh, they did a workshop in AIMS on ultrasound, so it's really coming up in with Padmanabha.
Yeah, even AFMC Pune is doing at CTC. Yeah. Any other questions for anybody? Okay, that was absolutely perfect. Very nice talk, Dr. Shenoy. Thank you so much for sparing your time today.
Thank you.
Thank you so much.
Thank you. Thanks, ma'am. Thanks for the kind invite. Have a great weekend. Thank you.
Have a great Sunday, everybody. Yeah. Bye-bye.
Thank you, everybody. Thank you so much.
Thank you.
Thank you. Bye-bye.